Hello friends and welcome back to the channel. I'm Dr. Mohsin Raj. I've done my MD from AIIMS New Delhi and now I'm a DM cardiology student at AIIMS New Delhi. Now in this video, I will discuss the most important ECGs that you're likely to encounter in INICET or NEETPG. Or if you're an MBBS student, these are the most important ECGs that you need to know for patient care. So this will be a little lengthier video than usual, but I'll make sure that इस video के through you will get to see at least once each and every important ECG. तो likely अगर exam में ECG based question आता है, एक या दो questions आते हैं, you will be able to get those questions right, guaranteed. Okay, so I'll discuss them. Slightly lengthier video than my routine videos. So I have divided these these ECGs into different parts. So I'll be starting with MI, which is the most important ECG that you need to know. I made dedicated videos on that separately. Now if you take a look at this first ECG out here, so what I want you to, now look, there are ways to interpret ECGs in detail. Whether the ECG strip is properly standardized, what is the rate, what is the rhythm, what is the axis, what are the P wave abnormalities, the QRS complex abnormalities, STT abnormalities, and so forth, or some arrhythmia that you need to interpret. But in this video, I'll show you the most important things in these particular ECGs. So for example, here I'm not going to talk about the rhythm, I'm not going to talk about the rate and stuff like that. But in this ECG, you have to pay attention to leads V1, V2, V3, V4, which are the anterior precordial leads, right? So you can appreciate Q waves have formed in these leads, and there is some residual ST segment elevation. You can appreciate ST segment elevation in V1, V2, V3, even V4. And there's T wave inversion. So this is an anteroseptal ST elevation myocardial infarction. So you have to remember this. Anteroseptal MI you should be able to recognize, and you should be able to tell me that this is an MI due to occlusion of left anterior descending coronary artery. Okay, so you know this is an anteroseptal MI, and you know this is an MI due to occlusion of left anterior descending artery. Okay, and even you can comment on the likely duration, the time since the onset of this MI. So it has been at least several hours because Q waves have come into picture, right? So this is an evolving MI. Now, what I want you to remember is the cutoffs for labeling something as ST elevation, right? So remember, for all leads except V2 and V3, the cutoff is 1 millimeter. That's it. You need to know 1 millimeter ST segment elevation in 2 or more contiguous leads. The exceptions are leads V2 and V3. Now in those two leads, you have these different cutoffs for men and for women. And different cutoffs for men if they are less than 40 years old or they are more than 40 years old. So for example, men more than 40 years, the cutoff for ST elevation in V2 and V3 leads is 2 millimeter. For men under 40 years of age, the cutoff is 2.5 millimeter. Now remember, this is only for V2 and V3. This is not for other leads. For all other leads, it's 1 millimeter. For women in V2 and V3, the cutoff is 1.5 millimeter. For rest of the leads, like men, 1 millimeter is the cutoff. Now if you look at right-sided precordial leads, that is V3R, V4R, the cutoff for ST segment elevation is 0.5 millimeter. So more than 0.5 millimeter, that's ST elevation. Okay. And what about ST segment depressions? The cutoff is 0.5 millimeter. Anything more than or equal to 0.5 millimeter depression in the ST segment is significant ST segment depression, right? Now, what is interesting in the next ECG is this is a very early patient who is presented quite early after his chest pain, and that's why you're seeing hyperacute T waves. These shown here in the leads V1, V2, V3 and V4, these tall and peaked T waves are hyperacute T waves. Now you can see, now this is 14:18, that's the time in this ECG. So it's roughly 2:18 p.m. and look at this ECG at 2 hours later. So what has happened, ST segment is clearly up, there is T wave inversion as well. So this hyperacute T wave has evolved into clear-cut ST elevation in the anterior leads. Again, V1 to V4 clear-cut ST elevation. What you also can appreciate here is the reciprocal change in the inferior leads. Look at the ST depression in 2, 3 and AVF. So a great thing to remember here would be an ST segment elevation in anterior precordial leads is anterior wall MI, culprit vessel is left anterior descending artery, and you are likely to see reciprocal ST depressions in inferior leads. Done? Okay. Now what you also need to know is that the earliest ECG finding is hyperacute tall T waves. Okay. But more likely, when the patient presents to your hospital, he'll be several hours down the line from the onset of chest pain. So you're more likely to see ST segment elevations and not these hyperacute T waves. Okay, so this is how an MI evolves. Starts with hyperacute T waves, then ST segment elevation, then T wave inversion, and finally the ST segment resolves and Q waves appear in all this. Okay. Now, there's another STEMI ECG that you need to be aware of, which is inferior wall MI. So in this situation, you see ST elevation in lead 2, 3, and AVF. So these are the inferior leads, which means this is an inferior wall ST segment elevation MI. What is also written in this ECG are these right-sided precordial leads, V3R, V4R, V5R. So you can appreciate that there is ST elevation even in right-sided leads. So I'll label this as inferior wall MI plus right ventricular MI. And the more likely culprit vessel is right coronary artery. Okay, so this is an RCA MI, right coronary artery is the culprit vessel here. Occlusion of right coronary artery proximally has led to infarction of the inferior posterior wall of the left ventricle and the wall of the right ventricle. Okay, then, so that's about MI. This is what you need to recognize clinically in your emergency or in the exam questions. Okay. So more likely you will be faced with such ECGs. You'll appreciate ST elevation in anterior leads. There will be reciprocal depressions in inferior leads. You'll label this as anterior wall MI. Culprit vessel is LAD more likely. And you'll appreciate ST elevations in inferior leads, 2, 3 and AVF, you label this inferior wall MI. And if right-sided precordial leads also show elevation, that's more likely in RCA MI. But remember, circumflex occlusion can also cause inferior wall MIs. But there's a separate video for that I have made, how to differentiate whether this MI is due to a left circumflex occlusion or this is due to an occlusion of right coronary artery, or at what level of LAD the occlusion is present. That's not for your purpose. For your exam purposes, you should be able to localize that there's an ST elevation, this is an ST elevation MI, and is it an anterior wall MI or is it an inferior wall MI? That's more than enough for your INICET preparation. Now coming to AV blocks. Now this ECG is important. I'll give you a tip here that whenever you see that there's clustering of beats, okay, there's clustering of beats, so 3 beats together, then there's a gap, then 3 beats together, then there's a gap, always think of Venn-Key-Bach phenomena. So what's actually happening in this ECG is that there's a progressive prolongation of PR interval. Okay, so if you appreciate it in lead 2, so this P is getting conducted, okay, then the next P is also conducted but with a more prolonged PR interval, and then the third one is dropped. This is not conducted to the ventricles. So progressive PR prolongation followed by a dropped beat, this is Venn-Key-Bach. This is second degree AV block, Mobitz type 1, what is also known as Venn-Key-Bach phenomena. Okay, now third thing, so we can skip this one. Now next is to appreciate third degree AV block. You should never miss this finding on ECG. So what you have here is the P waves which are being conducted, okay, which are not being conducted. The P waves are going at their own unique rate. The atrial rate is different. The ventricular rate is different and is low. There's bradycardia. And P waves have no particular relation with the QRS complexes. There's no constant PR interval. Nowhere do you find that P's are being conducted. So if you see, there will be P's, the P's are regular, they're coming at regular intervals. So look at this, P here, followed by P, followed by another P just immediately after this T wave. So these P waves are constant with respect to each other. Atria is beating at its own unique rate, and the ventricles are beating at their own unique rate. Okay, so this P and P interval is different. The QRS and QRS interval is different. No relation between P's and QRS's. This is a complete heart block or a third degree heart block. The next thing that you should be able to recognize is a left bundle branch block. Okay, so left bundle branch block is easy to remember. You have these deep QS. So first you have this deep S in the V1, okay, and you have this bifid M pattern in lead V6, and this duration of the QRS complex is prolonged. It's more than 120 milliseconds. So these three put together make a complete left bundle branch block. Now for your reference, I have put here the normal depolarization of the heart. So you know that first the septum gets depolarized from left to right, which is responsible for this initial positive deflection in the lead V1. And then because the left ventricle has more mass, the depolarization of left ventricle wins over the depolarization of the right ventricle. So you have the vector predominantly directed towards left, which is why the left-sided leads record positive deflection and the right-sided leads V1 records a negative deflection. Okay, but on the other hand, if the left bundle branch is blocked, then what happens? First, the right ventricle is depolarized by right bundle, and then the activation front, it crosses across the septum through the myocardium and then depolarizes the left ventricle, which is why the terminal part of this vector is directed towards the left. That's the V5, V6 are positive and is slurred. It is widened because the conduction has not happened through the natural conduction pathway. Conduction has happened through myocardium. Okay, so that is left bundle branch block. Now, what you can appreciate in this ECG is again left bundle branch block. You can see that you have these deep S waves here, the bifid M pattern in V6, it's wide, it's a complete left bundle branch block. But you also appreciate one more thing. ST elevations in lead 2, lead 3, lead AVF. So this patient has left bundle branch block, but also has an inferior wall myocardial infarction. Okay. Now some miscellaneous ECGs. Now this ECG could be a trick. They will describe to you a patient who has had some intracranial event, ischemic stroke, hemorrhagic stroke, whatever form of CNS event, some CNS injury, and they will show you an ECG which has these deep negative T waves. Now remember, there is a differential of some myocardial injury, but what I want you to know is that this ECG can be seen in people with intracranial bleed or an ischemic stroke. These deep negative T waves in precordial leads. Okay. Now, this is an interesting ECG where you find, now they will again describe a patient, some middle-aged person with chest pain, which is probably relating to the trapezius muscle. Okay, and here you see concave up ST segment elevations, concave up ST segment elevations, concave up ST segment elevations, and look, they're not conforming to any territory. They're present in lateral leads. You have V6 elevation, V5 elevation. They're present in inferior leads. You've got 2 elevation. You've got elevation in lead 2. They're present in lateral leads. There's elevation in 1. There's elevation in AVL. So they're not conforming to one territory. They are concave up. They're not convex. Okay, they're concave up, and in addition, it's very hard to tell from this distance, but there is elevation of PR interval in AVR lead. Okay, so these findings are suggestive of pericarditis. Pericarditis is a differential diagnosis for ST elevation. ST segment elevation is also occurs in pericarditis, but there are some differences. One, it is not limited to any particular coronary territory. These are more commonly concave upwards, and they are associated with these PR segment changes like PR elevation in AVR lead. Okay. Now, this is another important ECG that you may want to learn, which is Wolff-Parkinson-White pattern. Now, here in this ECG, I want you to focus on the PR interval, and I want you to focus on the initial part of the QRS complex. So here, the PR interval is shortened, and there is slurring in the initial part of the QRS complex. This is what is known as Wolff-Parkinson-White pattern, WPW pattern. And if this patient comes with symptoms, say of syncope or palpitations, then this pattern is known as syndrome, WPW syndrome. So again, you can appreciate in the base, in the lead at the bottom, short PR interval, slurred up stroke, followed by QRS complex. That is Wolff-Parkinson-White pattern. Now, there are a few more ECGs that are important. They're important clinically, and they're also important from exam point of view. And out of those are the electrolyte abnormalities. Do you see these tall and they're extreme, they're tented, peaked T waves? Look at the shape of this T wave. It's tall, it's peaked, it's tented, hyperacute T wave. Well, I've shown you one more similar T wave in a very early STEMI. But an important point to know is that these hyperacute tall T waves can also be found in hyperkalemia. So the reason I'm showing you this ECG is that this hyperacute T waves they're present in hyperkalemia. And if hyperkalemia is bad, it's even higher than that, then what you can see that there's disappearance of P waves. You're not seeing P waves. They're stretching a part of the QRS complexes. The QRS complexes are so broad. Okay, so this is how an ECG looks in a patient who has got hyperkalemia. It's important to remember this, it's important to know this, because if you don't correct hyperkalemia, this patient will surely die in few moments. Okay, and if you treat hyperkalemia, then this patient will live, and then you treat the cause of hyperkalemia. Okay, and the next ECG is that of hypokalemia. Remember, hyper and hypo both are life-threatening, and in hypokalemia, you get the opposite change. You get these, you don't get tall T waves, but they are flatter and there are prominent U waves. Look at this lead here. There's P, there's QRS, there's T, and then a U. So U wave appears in hypokalemia. In addition, the QT interval prolongs. The QT, there's a previous video on my channel on how do you calculate corrected QTC, but QTC interval is prolonged in hypokalemia. QTC interval is prolonged in hypocalcemia as well. So this ECG, which shows prominent U wave, a prolonged QT, it suggests hypokalemia. In addition, this patient also has sinus bradycardia. And this is what I was saying, in hypocalcemia, you again get prolonged QT interval. Okay, so let me tell you how you measure this QTC interval. So from the onset of this QRS complex to the end of the T, you measure this interval. Okay, and then you divide it by the RR interval. Okay, so by the square root of the RR interval. Actually, there's a formula, the Bayes' formula, that you know for calculating corrected QTC, and a rough value of 470 or 480, you remember, and anything in excess of that is a prolonged QTC. But here, and even there's a thumb rule that if you consider this RR interval, if you consider a midline between the RR interval, if the T wave is extending beyond that midline towards the next QRS, likely the QT interval is prolonged. Okay, so here even you can appreciate by that rule, this T wave is a lot away from the QRS complex. This is a clear-cut prolonged QT interval in a patient with hypocalcemia, right? And then this important ECG, they will describe you a patient who is hypotensive, has muffled heart sounds, has pericardial tamponade, has a large pericardial effusion, and look at this electrical alternans. You've heard of pulsus alternans and somewhere else, severe LV dysfunction, heart failure patients, but this is electrical alternans in a patient with massive pericardial effusion, with a swinging heart inside that massive pericardial effusion, which is responsible for this alternate QRS complexes which have high voltage, low voltage, high voltage, low voltage. That is electrical alternans, which is a feature of pericardial tamponade, another important ECG. Now, last couple of ECGs. Now, look at this ECG. This looks weird, right? You have some fast rate here and then a long pause in between. Okay, and this is what is known as tachybrady syndrome. Okay, so this patient likely has a run of atrial fibrillation towards the left of the screen. This is an irregular, fast, narrow, complex tachycardia, which is atrial fibrillation. And then the sinus node gives a pause. There's no rhythm at all in between. And then slowly the sinus node picks. This is a patient who is likely elderly, has paroxysmal atrial fibrillation, has simultaneous sinus node dysfunction, and this is what you label as tachybrady syndrome. Okay. And then this ECG, there are just a few remaining now. Now we're coming to tachycardias, the tachyarrhythmias. This ECG you can clearly see is fast, right? It is quite fast. It's quite fast. You're not able to appreciate any P waves clearly, okay? And it's narrow, complex, and it's regular. When you see such an ECG, fast heart rate, tachycardia, and narrow complex. The QRS is quite narrow, it's less than 120 milliseconds. It is regular. You're not able to clearly discern the P waves. You may find P waves if you look very carefully, for example, out there, but they're not very clear. So that's an ECG of a supraventricular tachycardia. That could be an AVNRT, or that could be AVRT, or that could be other form of supraventricular tachycardia. But this is what you know. Fast, narrow QRS, regular, think of SVT. Okay. So this is supraventricular tachycardia. Now this one is important. This is atrial flutter. Do you see this? This is actually an atrial flutter with 2:1 conduction. So atria are beating at rate of say 300, and then the AV node is conducting one beat, alternate beats, 2:1 conduction. So you get a ventricular rate roughly about 150. The atrial rate is there at 300, and there is no clear-cut baseline that is visible. That is atrial flutter. You're not able to see any baseline here. You have this sawtooth pattern. This is a P, there's another P embedded in this QRS, another P embedded in the QRS, another. So this is like a sawtooth appearance. This you can appreciate in multiple leads, sawtooth appearance. This is atrial flutter with 2:1 conduction. Okay. Now next I want you to appreciate what a ventricular tachycardia looks like, which is here. This is a ventricular tachycardia. Now this tachycardia has wide QRS complex. So tachycardia, wide QRS complex, regular, your differentials are ventricular tachycardia, or it could well be a supraventricular tachycardia, but there has to be some aberrancy. If this patient here had a right bundle branch block or a left bundle branch block to begin with, then this QRS would look wide because of that right bundle or left bundle branch block. But more common than that, if you have a regular wide complex tachycardia, it is a ventricular tachycardia. Now there are two things that you need to know, that which is like a sine qua non of ventricular tachycardia. If you find this finding, that is ventricular tachycardia, which is here. One is this capture beat. You see, these QRSs are wide, they're regular, but in between there is this small little QRS complex which seems like a normal QRS complex. So this was that occasional one which was conducted from the atria into the ventricles. This is a capture beat, a capture beat, a capture beat. And somewhere you find that it neither looks like this very small complex, and it neither looks like this tall QRS VT complex. So this is a fusion beat. It's likely a fusion of the sinus beat and the VT. Okay, so if you find this, a wide complex tachycardia, and in between these small complexes, these are capture beats or this different sort of a morphology, fusion beat, that makes it ventricular tachycardia. That makes it ventricular tachycardia. Okay. Again, shown in this picture, you have a fast heart rate, it is regular, QRS complex is wide, and you have these fusion beats, capture beats, that shows it is ventricular tachycardia. Okay. This is again a wide complex tachycardia. You see this? It's a regular tachycardia, wide complex tachycardia, and your differential most of the times is ventricular tachycardia. Okay. And you can also appreciate in this picture there's AV dissociation. You find these occasional P waves in between, and if you go on counting, you'll find more QRS complexes than P waves here, which is AV dissociation, which means ventricles are beating faster than the atria, which is what is ventricular tachycardia. Okay.